orthopedic spine fellows, where we got to practice some of these techniques, and I'll kind of highlight some of the things that we had learned from them. Some background on the rationale for the technique. You can basically do many of the decompressive spinal operations through a small, about 1 centimeter stab incision and minimal muscle dissection, which has benefits for decreasing the devascularization, denervation of the muscle, hopefully decreasing the pain, and also the amount of bony resection that's required, because you can make a targeted focal trajectory to the exact pathology that you need to get to. And this minimal approach has hypothetical benefits of decreasing the complications from infection, hematoma, and CSF leak, et cetera. And ideally, that because of the MIS nature of the operation, patients can mobilize faster after surgery, get out of the hospital sooner, and patients who may not be able to tolerate general anesthesia may be able to tolerate this operation under MAC with some local anesthesia infiltration. So you could broaden the amount of patients that are potentially candidates for surgery. There's been a lot of study of this on the last about 20 years. Most recently, a RCT was done comparing open microdiscectomy versus an endoscopic approach for patients with a herniated disc and sciatica. And overall, they found that this is the endoscopic approach is non-inferior to conventional methods, and even may have less of a duotomy risk and have benefits of getting mobilized sooner and getting out of hospital sooner. Other meta-analyses have found that compared to larger studies from the history for the experience of discectomy from the sport trial, that possibly there's less risk of having to reoperate and having a lower incidence of CSF leak and infection. Other meta-analyses that have looked head-to-head of the endoscopic approach versus the discectomy approach found that most patients are experiencing less back pain immediately after surgery and at follow-up. But overall, it's about a wash, about the functional status with regards to leg pain, health status are about the same. In general, the blood loss is less, but it takes the surgery is a little bit longer relative to discectomies. Patients generally get out of hospital a day sooner compared to conventional approaches, and the complication rate is about comparable from the most high-level data. Endoscopy is being mostly pursued in East Asia and in Germany, but there's continued emphasis on this in the United States. And over about the past 5 or 6 years, there's been an explosion in the literature on describing these techniques for spinal pathology. Brief history. And the endoscopic surgery in general really took off in the 70s as field orthopedics had developed near techniques for endoscopes for joint operations. And around the same time, in the sphere of pain management, IR-guided approaches to this space were being developed by Dr. Camben. And early on, they were performing discectomies, all blind, basically. And then once the endoscopic technology got better, they started being able to do this using the endoscope to watch the operation that was being performed and starting the first endoscopic discectomies around the 80s. As the endoscopic technology got better and they had larger scopes and better working channels, more conventional microinstruments were able to be developed. And we saw this in the ENT and cranial neurosurgery side, from skull-based surgeries and from neuroendoscopy. In the 90s is really when the endoscopic spine surgery started taking off. The newer endoscopes that were developed allowed for continuous irrigation during the operation. Initially, people started putting the scope all the way down into the disc space and working from inside to out. But as new bone cutting instruments, reamers were developed, we were able to start the decompression from the outside and work in by performing foraminoplasties under direct visualization. That's how the transforaminal approaches took off. In terms of the interlaminar techniques, in the 90s and 2000s, tubular retractors for the spine were developed by Dr. Foley and Medtronic, et cetera, and allowed to use microsurgical instruments down the tube. And then these principles are applied to endoscopic spine surgery, and that's how we are where we're at today. This particular anatomic region was very important for identifying safe corridors to the disc space and to the nerve roots. Is Brandon Philbrick on the line? I have one question. You could tell us what this triangle is.
So the red triangle is Camden's triangle.
Okay, that's good.
Made of the,
can you tell us the boundaries?
Yeah, the other ones are the exiting nerve root, the superior end plate of the inferior level, and then you have the traversing nerve root going to the exiting at the level below.
Yeah, that's exactly right. This corridor is basically your safe zone for getting to the disc space and getting to the nerve, which you can see on X-ray, and you can make sure that you're not putting these structures at risk. And it's about 1 by 1.5 centimeter area. In terms of planning routes to perform an interlaminar decompression, really depends on how the disc is migrating. If it's sweeping cranially or caudally, you may want to change how you place your tube. If you look from caudal to cranial or cranial to caudal, and then depending on how far central to lateral the disc herniation is, you may not be able to do an interlaminar approach, and you may need to use a transforaminal approach. And your targeting is very important in terms of positioning the patient, getting the X-ray to get the correct view that you need. When you're doing these cases with fluoroscopy, you need to make sure that you have a true AP and lateral of the level of interest, so that you really need to identify that when your X-ray tech gives you a picture, that you have a clear, solid end plate of the index level. You need to see the pedicles well. You need to make sure the spinous process is midline, so that you know that what you're seeing is reality. And similarly for lateral view, you need to make sure that the end plate of the operative level is total one solid line. You make sure the pedicles are aligned, so that you have a crisp, good view, so you can do your higher guided approach safely. And then there are position changes you can make with a patient with the Trendelenburg of the bed, the rotation of the bed, or the X-ray tube itself, to make sure that you have a perfect view before you proceed. One of the hardest parts about the operation is all about the setup and getting your targeting accurate, so that you get where you think you're going to get.
Can you explain that
in terms of
that picture there?
Yeah, so there are 3 views here. This one is inappropriately aligned. As you can see, the X-ray beam is cutting through the superior spinous process, and it's not quite parallel to the disc space. So on the AP, you're having shadowing of the posterior border of the superior end plate and the anterior border. So the X-ray technologist was instructed to start doing a Ferguson procedure to drop the craniocaudal angulation of the X-ray tube, so it's looking through the spinous process and cutting into the disc here. And this identifies where identifies the trajectory that eventually the dilators will go down.
What is the green line, the green dotted? I know what the red line is and the green arrows, but what is the green dotted line?
That's a representation of the interlaminar space, where the
Ah,
ligament, like where ligament flavum is, and there's not hypothetically any bone.
okay. Thank you.
These X-rays show how to target for a transforaminal approach. On the on the AP, your safe zone is basically lateral to the medial border of the pedicle, which is outlined in white here, and it's around the 10 o'clock position. Any more than that, you're starting to violate fecal sac neural elements. So you need to see that. And then on the lateral view, you need to see the posterior spinal line from the posterior end plate, the posterior aspect of the vertebral body. You can't be any deeper than that. And ideally, your guiding needle will be at the superior posterior corner of this end plate. And if you're planning to perform a foraminoplasty, ideally it's going to cut across the SAP of the lower level, because you're going to, with your dilating instruments and reamers, you're going to remove this bone so you get access. And then you can, once you have confirmed that you have a safe entry site, then you can put guide wires down to get into the disc space, and you can put biting instruments, etc. And you'd be doing this, you'd be endoscopic at this point with this instrument in place. Of course, you don't have to use X-ray. We've, last couple of years have developed a lot of CT guided approaches to the spine, and you do the same thing that if you're doing for MRI spinal fusions, you can use the same type of guidance technology. And the advantage is that you get with your pointer, you can get a constant 3D representation of the spine in real time. Whereas with the X-ray, you have to keep taking X-rays and seeing where you're at. There's two options. And this wasn't done in our hospital. It's another author. But in this case, they had a patient with a cervical disc herniation, and they used the O-arm with a patient in pins with a stealth reference array to find a corridor to get to this disc herniation. And then they performed foraminotomy, and then they performed discectomy posteriorly. Here's the disc here, and this is after they removed it, and this is the bony work that was done, which spared the patient an anterior approach and fusion. In terms of the equipment, the standard endoscope, most of them just look like this. It's about a 6 or 7 millimeter outer diameter of the endoscope. There's a working channel. It's about 4 millimeters that you can put your microsurgical instruments down. There's a camera that has varying degrees. You can have 0, 25, 30 degree scopes. There's a light source that you hook up to your standard tower. And then there's a port for your irrigation. Some have 2 ports, some have 1, but you can get continuous irrigation. I'll go through that in a little bit. These are other manufacturers. This particular manufacturer has several different sizes of the endoscopes with differing sizes of the working channels, depending on what's needed for the operation. There's, like I said, there's different optical angles, just like from cranial neuronoscopy. Once you have targeted the site that you need to get to, there are several different types of cannulas that are inserted. You have some that are beveled, which allow you to rotate and retract. Basically, you can retract the nerve root, you can retract the fecal sac by turning your cannula. Other ones, one that's not beveled, you don't have that option, but it just depends on what operation you're planning to do. Most of the endoscopic operations in the United States are performed through one scope. In South Korea, they've really been pushing by portal. So you have a working channel on the caudal aspect of the spine, and you're watching directly what you're doing through the cranial aspect, through the same type of scope that we showed earlier. And then you can play around with what camera you place down, so you can get different views depending on if you're looking cranial to caudal, caudal to cranial, to make sure that you're getting all the decompression or what surgery is needed. You can hook up to whatever type of light source the hospital has. For instance, at Sinai, we have the Source Towers it integrates well with that. The irrigating ports, on the endoscope, you can hook up to continuous fluid irrigation. And this is very important for the operation. One, because it continuously irrigates any debris and blood that's encountered during surgery. It also has a tamponade effect, so you can irrigate and occlude the outflow from the endoscope so that you can create some back pressure. If you have bleeding, you can also intermittently do that to see how the neural elements are responding, to see if you're decompressed. It's important that the pressure from the irrigating tubing, which you are able to control, is less than the diastolic pressure of the patient, because if it's too high, then you can bisect into the epidural space and cause real compression. So it's very important to be mindful and talk to your anesthesia colleagues about what they're seeing the blood pressure doing and what your irrigating tubing is set at. That's very important. In terms of starting the operation, it's all, as I showed earlier, it's all about placing your needle where you need to be. You can place a needle down, look on X-ray. You can put a Jamshidi down. For interlaminar approaches, you can just go straight down with this dilating tubing. For transforaminal approaches, you want to place your docking needle and then serially dilate with incrementally larger tubing. In between the dilations, you want to perform foraminotomies, foraminoplasties, so these bone-cutting reaming instruments. So you'll put a tube down, and then you'll put the corresponding reamer that you rotate, and it cuts the SAP so that you have less inhibited access to the nerve frame and then to the disc space. An innovation that's really helped with these operations is the development of a radio frequency probe that has a couple of cool characteristics to it. One is that there's a handle that will extend the tip of this bipolar instrument so that you can both get curve and get access to more difficult to reach areas, but also gives you both length and width of coverage. You can bend it. This is like a flexible tubing. You can bend it and create an angle that you need if it's the preset one's not working for you. It has a cut feature and a coag feature similar to Dr. Mouse's original bipolar. And then the conventional microsurgical instruments for spine have all been adapted for endoscopy. It's just that most of these are on a trigger handle, long working shaft, and the same type of tips that we normally use in our standard operations, both for dissecting, for cutting, for grabbing. And then there's other specialized hand drills and bone cutting instruments that have also been tailored to these approaches. In terms of setting up the room, the surgical team will all stand on one side of the patient, opposite from the C-arm and the large detector of the C-arm, and I'll look at the monitor. All of the other towers are at the foot of the patient and head toward anesthesia, like standard. Because of the continuous irrigation from the endoscope, you're going to get a lot of water runoff during the case. So it's important for the setup for you and for the patient to really place your eye band so there's no gap, so that all the irrigation will run off. And you need to Dr. Margettis likes to put pockets on the patient to collect the water, and then put like a suction tubing down it. In this case, they showed putting the C armor down and just collecting all the irrigation that will accumulate. There's a lot of different pathologies that can be addressed with the endoscope. And this is probably one of the more straightforward ones. This is a patient with mostly lateral recess stenosis. A couple of views down the scope. First, to identify the anatomy. Basically this is the head, this is the feet, and they're removing the lamina here. Now they're in the epidural space, and they're removing ligament and seeing epidural fat. Starting to turn the corner, look around the lateral edge of the dura, and now in the lateral recess, the SFP here. This is remove the bone bonding instruments, starting to see the nerve root. And then in this case, they put a dissector down, mobilize the thecal sac, and just visualize the ventral space. And there was a small disc herniation there. Drilled some more, took the disc out, and then just were able to view that the neural elements are nicely decompressed. This is an example of doing similar to that, a discectomy using an interlaminar approach, doing the laminotomy, removing the epidural tissue, the flavum, and then decompressing and identifying a very discrete disc herniation and removing it. This is the microbipolar dissecting. You can also address contralateral pathology by going basically over the top. So this is a patient that mostly left side neuroferrimal stenosis. In this case, the tube is docked starting from the contralateral side and undercut the spinous process and lamina, and then went over the ligament flavum, resected that, and it got all the way down into the contralateral space. And then found the nerve root, nicely decompressed that. One of the more challenging approaches for endoscopy, which is pretty straightforward for conventional techniques, is doing decompression for central canal stenosis. This person's mainly issues with central canal here. And the operation is similar to one I showed before. It's cutting the lamina, undercutting the spinous process, removing all the flavum, which is here, and basically removing all this tissue through a small port that's trajectory aims that way. One really great application for this is lateral discs for lateral disc herniations, where no bone removal is really required at all. The hardest part is targeting. So this is just an X-ray showing how these authors identified the lateral, identified that they were lateral enough, and then they found a focal disc herniation and removed that. And this is an example of doing this transforaminally. Again, a lot of the case is just getting the right view and getting to the right spot. And similar to the previous cases I showed, it's just removing bone, stripping off soft tissue, and removing bone and getting the focal disc herniation out. When durotomies happen during these operations, it's I've been told it's not as big a deal because
Just lost your audio, Travis.
Hello, can everybody hear me?
Yeah.
All right, so really sorry about that. In these operations, duotomies can occur. I've been told that generally it's not as concerning compared to open operations because it's a small stab incision, and a lot of the hydrostatic pressures of the soft tissues will tamponade any CSF leak that occurs. But there are a lot of strategies to fix the duotomy if it does occur. It does occur rarely, but it does occur with these operations. One option is to put some type of dural sealant down. You can take the tips of your bipolar forceps and you can weld it shut. You can place clips down, like this example here. And one strategy that people talk about is taking a piece of gel foam and just tucking it into the duotomy, and that usually takes care of it. Another thing that frequently happens during these operations is that blood loss is really harder to control than it is in conventional operations. One strategy is to just avoid getting into it and just taking your time carefully, because once you start having bleeding, it really just fills your view. It's all red, and it doesn't really, you don't get a better view until you really get control of the blood. One option is to turn your irrigation up and occlude the outflow so that you get some back pressure. But that's generally one of the things that has at least here has kept from doing a lot of these operations. So the examples I showed you are probably the more straightforward approaches. There are people that are pushing it for cervical decompression, thoracic decompressions, which have their own additional complications because you're working on the cord, you're working on the pleura. And there are people that are pushing for doing fusions using endoscope assistance. And it's basically, for example, doing a transforaminal lumbar interbody fusion. It's the same trajectory as we're doing the discectomy, but then there are other bone cutting instruments and disc space preparation instruments that you would use. There's drills you can use. There's reamers you can use, and you can use the endoscope to look down and see how well your end plates are prepared to maximize the bony contact surfaces for fusion. And people have published on this, and so far the fusion rates are similar to conventional open or MIS TLIFs. And then Dr. Wang at Miami has been pushing to do this for awake patients, because you can imagine if it's just the stab incision, not much muscle dissection, you potentially could do this with an awake patient that can give you real-time feedback with their neurologic exam. And it seems that the operative times aren't too long, 90 minutes to 2 hours. People have reported on their learning curves and trying to pick up this technique. This is an example from that prior RCT that I had shown. There was basically a trial educational and proctored period for the surgeons that were part of the study. And overall, they got a little bit faster after their first 75 cases. Got a little bit less blood loss. The complication rate was a little less. However, the reoperation rate was still high in this initial index group. It later got better, as I showed earlier, but compared to the open group, 6% had a reoperation versus 12% in the first early experience for these surgeons. This is another kind of anecdotal paper that looked at surgeons that had prior significant MIS experience versus those who were picking up the technique from a new. And overall, people that had extensive MIS training were faster and had less complications than people that were picking up the kind of was carried on from the first 1 to 60 cases that they had done. And then in terms of people's motivations for getting interested in spinal endoscopy, this is a study that was done via survey in Thailand, most people felt that they needed at least 3 courses or workshops before they would be comfortable taking it to one of their actual patients. Most people, surprised, are motivated by like personal interest and marketing more so than patients wanting it or the hospital wanting it. And the things that people had cited most frequently was the lack of support from the hospital and the fear of getting into complications, and the cost of the capital costs for the equipment, the cost of the patient were the main contributors to challenges. And I just want to show last just one example from Dr. Margettis, a video that kind of ties these elements together. A patient with paracentral disc herniation. Dr. Margettis is removing the ligament flavum and getting down to the fecal sac, starting to see the lateral nerve, the epidural space, and then money shots coming up. There's going to be a large disc herniation that he finds and removes right there. And I'll show you an example when bleeding occurs and how that can be controlled. So there's not much bleeding, but it really takes away the whole field, and then just a dozen with the bipolar seemed to have taken care of it, and everything looked good at the end. This patient did well. Thank you for entertaining this talk. I appreciate the time.
Thanks, Travis. That was a nice overview. And actually, I think we're planning to have a visiting speaker discuss endoscopic spine surgery probably in a couple months. So it'd be nice to